So good morning to all. Today we are presenting the grand rounds in hepatology, and the theme we have chosen is artificial intelligence. This presentation will be covered in three forums. I will be giving a small case scenario for multimodal artificial intelligence. Dr. Ashok Chaudhary will be covering on NFLD and ACLF based cases for artificial intelligence, and Dr. Manoj Sharma will be covering on the basics of artificial intelligence. So, giving a clinical scenario, this is a 34-year-old male with fever, jaundice, altered sensorium, appears drowsy, HE grade 2 to 3 on examination, and has a bilirubin of 11 with a high AST, ALT, and INR of 5.4. The clinical diagnosis is acute liver failure, hyperacute liver failure, and King's College criteria is 3 by 5. On your left, you have the CT, which shows diffuse cerebral edema, and the optic nerve sheath diameter is 5.4, and the ammonia levels are 289. So the first question is that this is an acute liver failure with AKI, with high grade cerebral edema, with HE grade 3. Now, if you were to prognosticate this patient, so two of the very important things that you need to keep in mind when you're giving these decisions, especially in a clinical scenario, is will this patient survive medical management in the absence of liver transplant? As most of our patients do not have a transplant option when they present to us. And there's no donor at present, but they need a transplant. So how soon can we transplant these patients if at all the medical management does fail? So the prognostic models of ALF, as we know, most of these are well-validated models, have shown that there is limited sensitivity or specificity in most of these models. And more commonly, all these models used mostly bilirubin, INR, creatinine. So they use all the clinical data set which is available, and none of these have tend to be very specific, rather being more insensitive, though still we use the King's College criteria. There are others like the Alfred score and one which was also done at ILBS, which are dynamic models, but still all of them still include clinical database and not include any other form of information which is required for a patient of acute liver failure. So that's shown in the first slide. The patient had diffuse cerebral edema. And as we know in ILBS, we have an ALF corridor where the patient comes into the emergency, goes via the CT scan, a CT head, a CT abdomen is done, and then the patient is then shifted up to the ICU. So the first question would be asked is, why do we do a CT scan? I mean, the patient can go to the ICU straight away. So does imaging have a role in acute liver failure? There is only one study of imaging, which was published in 2019 in Liver International, which looked at liver volume, and they had proposed that a liver volume more than 1,000 could indicate an adverse prognosis. But other than that, there hasn't been much which is done in the field of imaging. This was some small work we done about 5 years back, where we looked at the liver volume and predicted an ALIF score. And this also had shown that if you have an hepatic encephalopathy of grade 3 as one of the criteria markers and an important criteria marker, this would predict adverse prognosis. But as we know, for cerebral edema, till now, we have not looked at the CT imaging. We have looked at the optic nerve sheath diameter, we have looked at pulse rate, we have looked at the hepatic encephalopathy, but we probably have not looked at the most direct evidence we have of cerebral edema, which is the imaging. So it is an under-quantified driver. We all understand that it is the cause, one of the leading causes of death in acute liver failure. And there are now very good data, especially even from our center, showing CRRT is a very important tool for ammonia lowering. But we still do not look at cerebral edema from the most direct source that we do every day, which is a CT-based imaging. So this is where the role of possibly artificial intelligence comes in, that can you integrate all of this data, which is including the imaging data, for us to find a score which includes a multimodal score of imaging plus a clinical data set. So this was a data set of nearly 183 patients where we looked at two objectives. This is still a work, and I thank Dr. Isha for the work that she's been doing. And this is still, we are in the process of making this better. The first objective was predicting the mortality. And if you look at, there are three models that have been constructed: M1, M2, M3. First is the RNN, which is a recurrent neural network. Just know the names. I will give you in brief of exactly what they are. A transformer-based model using CT and a combined late fusion model. And we've also looked at an objective of predicting the urgency for liver transplant. So using either clinical or dynamic clinical data set, can you predict the urgency of liver transplant in spite of the patient receiving medical therapy? So these are 187 patients. About 183 have clinical etiology, dynamic clinical variables, but about 106 of them had a baseline non-contrast CT scan. So most of the clinical data processing has been done using the following state. And if you look at the CT here, these are real case scenarios. These are three different areas. As you can see, this is the basal cisterna, the third ventricle, and the lateral ventricle. So when the model was being created, these are the three areas which give the maximum information when you're looking for cerebral edema. And also you look at the Hounsfield unit. So as we all understand, the Hounsfield units indicates level of perfusion. So between the Hounsfield units and the areas that you can see on the CT scan, you can slice these CTs. We call it segmentation also. You can look at which of these slices gives you the maximum information when it comes to cerebral edema. So this model, if you can see here, I'd use the word late fusion. I will come back to it. This is the clinical data set. You have clinical data set and you have the imaging data set. The imaging data set is sliced on the anatomical boundaries on the Hounsfield unit calibration. You have three different areas that have been chosen, which is the basal cisterna, third ventricle, and lateral ventricle. You do a map generation. You then create a transformer, and a transformer then eventually creates a model by late fusion. And this is where you run the neural network. So this is a combination of all the clinical data as well as the imaging data, something that has not been possibly studied in patients with acute liver failure as yet. So this multi-model prediction for mortality showed that if you just use a recurrent neural network, your accuracy was nearly 92%. But if you use a late fusion model, it was close to 81%. So it's three different models showing very good accuracy, very reasonable accuracy. Still, we have more data to process. Shows that you can use a multimodal data set using imaging and dynamic clinical variables to arrive at these conclusions. Now, this is a SHAP analysis. You will see this a lot in AI publication. This is the Shapley additive explanations. This basically gives you the regions of importance. So what was the most important was age gave you the maximum percentage. You had ammonia levels. You had the use of CRRT. You had an etiology of drug-induced liver injury, and so on and so forth. So the SHAP analysis gives you which variable gave you the maximum importance while you created this model data set. And this very clearly is a 2D CAM imaging, which shows of the certain areas which actually drove the model to predict mortality in the subset of patients, barring from the third one that I had shown you. So now you have on the CT itself, you can map the areas of regions of interest, which will give you the maximum information when you create a data set. Now, for prediction of mortality, as you can see here on the green is our model that is the late fusion model, has close to 89% accuracy in prediction of mortality for patients with acute liver failure. So the score is that if it is 0.5, it is a high risk of mortality. Less than 0.5 is a possible survivor. What we did was we took 4 patients, blinded Dr. Isha, and asked her to predict the score and what was the actual outcome. So if you see here, patient 1, a 90-year-old female, predictive score of 0.4, should survive, and this patient actually survived as per the actual outcome. And if you look at a 45-year-old with cerebral edema, predictive score for 0.6, and this patient unfortunately did not survive on day 1. So there are some test cases. Of course, there is much more to be done, but this score can actually now predict using CT as well as clinical data sets to predict the outcome of these patients while they come to you to the hospital. Second was predicting the urgency for liver transplant. So again, you created 2 models. One was a dynamic model and the other was a baseline model. When you created both, what you found out that this model also predicts of nearly about 75 to 80% accuracy in predicting urgency for liver transplant. When I call it urgency of transplant, these are all patients where medical therapy has already been given for the last 48 hours. They do not have a donor. These are the data sets that we had. And how urgent is a transplant for them? And if you can see here the ROC, and this is the curve which is with the red, which you can see here, is almost comparable to the groups which are there. So there were 3 scores that have been created. One is if the patient has 0.6 is a high urgency for transplant, 0.3 to 0.6 moderate urgency, 0.3 is low urgency. We looked at 3 blinded data set, and as you can see here, this patient has 0.24, which is predicted urgency, did not make it up to at two days. So this is I wanted to show this to show that not all models are always correct. There can be certain fallacies, but if you can look here, if the score is 0.5 or 0.7, these patients survived after undergoing a liver transplant. So this score can also even make probably a prediction of how urgent these transplants are required, because in our setting, most of the times we do not have a donor at presentation when these patients come to you with acute liver failure. So short on multimodal data. And as I've said, the multimodal data combines different data types: imaging, clinical notes, genomics, if you have that data, and all of these combined constantly outperforms unimodel data. But these are not for all etiologies. You will see in the subsequent slides by Dr. Shok that even unimodel data gives accurate information based on the types that you are actually creating these models. So I kept discussing about what are transformers. And if you can see here, this is for our patient who's got an acute liver failure. If I want to know the query for high ammonia levels, which are the factors which predict the factors? So you have INR, hepatic encephalopathy, you have CRRT and bilirubin. If you see here, the darker shades are the one for the weightage. So the ones who are more darker have higher weightage as compared to the ones who have lighter weightage. You have a recurrent network and you have a transformer. A recurrent network is something like which processes one thing at a time. So for example, if the patient was admitted for 5 days, the model will first look at day 1, then look at day 2, then look at day 3, and then look at day 4. So it processes one step at a time. When you use a transformer, if you have the 5-day data, it processes all the 5 days data at one point in time. So it runs multiple parallel models at one go rather than a single model at one time. And that is the reason why the transformer-based data showed you a better accuracy as compared to the RNN data. There was something called as fusion, something known as an early fusion, a joint fusion, and a late fusion. An early fusion would be that if a patient comes to you with acute liver failure, the patient undergoes a CT scan, the patient undergoes multiple testing, the clinician has seen the data, you take the whole data and you analyze it, something what we do in statistics. So you have a concentrated data and you make a prediction. A joint fusion is where the radiologist makes a diagnosis of cerebral edema. We make a diagnosis of cerebral edema based on certain clinical parameters, and both of us come on a common platform and give us our input. However, the late fusion is a data which is more so with our judicial system, where there is one side, a radiologist predicts cerebral edema. We probably say from a clinical standpoint, the patient does not have cerebral edema. And there is a third observer which gives out a verdict that is there edema or not. So that is why most of the models, late fusion turns out to have the best model because it analyzes each of the data sets and gives you one single verdict rather than giving you multiple verdicts at each point in time. So this is very brief on what we look at multimodal data. So to conclude my part of it, I would suggest that for clinical data for acute liver failure, in a short example, brain imaging gives you a good combination of other data, gives you the best prediction mortality. These are explainable, supporting clinical trust adoption. And these do show promise with high accuracy precision, but very important, the kind of data sets you have, the kind of etiologies that are in place for us to use. You cannot use multimodal data for every scenario. There will be scenarios where a unimodal data will be good enough, and we'll see in the next slide on how a unimodal data gives you the best information. Thank you.
Thank you, Harsh. Just 2 brief points while Ashok is going is we could add ONSD as well as transcranial Doppler or maybe BIS into further model development.
Right.
Thank you.
Good morning, everyone. Actually, thanks to House for making easy, and also my great regards to Mano sir. He told that his topic is very difficult. Also, I have seen through his slides. He permitted that you also go fast. So we are thinking artificial. I think now this person was initially the genuine intelligent, natural intelligence, and hopefully the AI will make you everyone to having a augmented intelligence. So this is the journey. Initially, we thought of it is a basket. First comes the machine, then a deep. Now the generative AI. And generative AI is now taken what you are using daily. This NLP, LLM, or the chat GPT is the final version of the genetic AI. So what we have done that we want to show. So first of all is the fatty liver. This is a dream that when a patient comes to you, you can tell everything that he's having so much of fibrosis, so much of activity of steatosis that will likely replace the biopsy. So I have tried with this. So this is what we have tried, a model of having the FET model with advanced fibrosis, that is F3 and F4 to 22, and non-advanced fibrosis, that is 0 to 1 to 2 is 230 samples. And then this is about the parameters we have taken, and this is the model which shows that this simple model having these parameters as the supply curve having the most total model, having accuracy close to 82% accuracy and is better than FIB4, which is the standard till now, and also from the APRI, much better. And then we go for this. So this is the model which is come up, and the score is very simple. You can see here. This is what you put into. We have developed a web-based model. Put the age,
Go
platelet.
back to previous slide. Explain this to everyone.
So this is how we have developed. So this is taken the biopsy proven fibrosis models, and then these are the parameters, demography, all clinical parameters. Then do we develop the model. So this model is having accuracy close to 84, F1 score is 0.77, NPV is 81, and positive predictive value is close to 91%.
The gold standard is the biopsy.
Yes,
Then
this,
we put the metabolic parameters into.
yes. So this is against the biopsy because all having biopsy proven. And with this, there is a top 5 and the whole parameters. So 4 is 16 parameters. We tune down to 5 parameters, and this is very simple to be used. Age and history of diabetes. So this is very much can be done easily without any investigations. You take one platelet count, age, and a cholesterol. So these 5 parameters can able to tell this, and this is the deployable web model which is available with us. To publish this is also published as also is after before in ESL. And to further validate, because that time core sample was 452. So we have now developed, this is submitted for the ASLD this year. We've taken 1300 patients with fibrosis 560 as less advanced, 749 are the severely advanced fibrosis. Then we've taken all the parameters full, that is all 16 parameters. Then we've taken the modifier, that is only simplest 5 parameters. You can see here, it is all are closing to 80%, both in accuracy, sensitivity, and specificity. And most interestingly, the currently gold standard for the practical use biopsy is definitely the FIB4 is 0.71, whereas our model is coming 89. So 88 is when you use 16 parameters, but when cut down to 5 parameters, still we are getting 89% accuracy. And to further tell that these persons, if you're coming to us, we developed a MAPS tool, that is whether he is having 4 groups: normal, that is earliness, actressness, or advanced fibrosis. So when we go for this, you can see here the random forest strategy is best. You are using the parameters only LTST ratio, age, BMI, platelet, uric acid, and GGT. So these simple parameters can tell with accuracy close to 86% that whether he is into which group, that is his earliness, actressness, or advanced fibrosis. And this is also against for the 1700 patients with biopsy proven data. So this is very simplest way to identify all patients in OPD who are high risk. The previous model was for the field use for having high fibrosis. So then we thought how we can replace. So this is a review article we have submitted. This is how the images are going to fix these models. That is the radionics. Now the digital imaging. The digital imaging has shown to replace with 20% advance to predict the fibrosis. This is a review article I'm not highlighting. Then this, this is the previous this in between. So now they will need transition for the fatty liver care. That is episodic time consultation with limited follow-up. Whatever the treatment, the lifestyle behavioral medicine is the main treatment. We need personalization, which is lacking the current therapy. Clinic visit, we need alcohol abstinence counseling, that is only once. Poor adherence to both alcohol as the lifestyles and into healthcare burden. So what we thought of that, identify high risk group based upon polygenic risk profile, calculate their comorbidities, their lifestyle, their behavioral pattern, how they are getting real-time alcohol exposure, because maximum patients are coming to the metailed category. Then plan a pathway there for individual and precise medicine, integrate the digital and AI-based interventions, regular reinforcement by chatbot, voice assistant, or digital coach. Then the whole aim is to shift from reactive episodic care to proactive, preventive, and patient-centered care. That will improve the advance and long-term care. For this, so this is the SAR is the PI. We have taken a model how we can develop, including all these parameters, that demographic, clinical, laboratory parameters, genomics, and imaging to get a model. And then we'll go. I think till now we have retrospectively collected 1400 data, and prospect also going on. So this is for the diagnosis, how we can improve. So this is what the digital twin. The digital twin is that you collect all that multiple data, you profile the patient that you are having this, then make the trajectory, then you think of making these indicators, decide personal treatments, and then their activities monitor. And this is can be a big throw how you can manage the patient from diagnosis, treatment, treatment complex, and the outcome. And this is the thesis as the PhD I have taken this. And once the fibrosis is converted or complete, then comes to cirrhosis. Till now, we consider HCPG for the portal pressure assessment. And I know everybody know this is such a costly, invasive, as well as limited facility available. So this is what initially we developed. ResNet, as Dr. Esa told, this is the standard model used for the image segmentation. So we have developed a model where we categorize the patient to having HCPG of 0 to 5, 6 to 10, 11 to 16, or more than 16. Then this model is having taken as curve how to predict this. And this model is not accurate, so we thought of developing a clinical radiography model. What we have taken the images, we have done segmentations, featured the extractions, then put the clinical parameters, and this is called the clinical radiographic model. So this clinical radiographic model we have developed in having 152 total 236 patients with the training data of 178, validation 58. This is the ground truth. We have taken the whole liver, excluding vascular structures. And these are the sub parameters. You can see only two parameters coming clinically, that is platelet and the ST and INR, and the rest of the parameters from the image, radiomics pixel data. So when you have done this, the clinical picture has accuracy of predicting significant potential. We have taken that more than 10 as the CSPS, then 68% accuracy. If radiomic is 83, when combined clinical radiomic, it is predicting 90%. And this is by the different methods. Here also we found that random forest is the one of the best model to predict the virtual HVPG, that is a clinical surrogate for the total hypertension. This is also the abstract for the SLD last year. So once we have seen the fibrosis, total hypertension, then we come to the liver failure. So this is what thought of that a patient coming to the liver disease have three things, either ACLF or acute disease or a decompensated cirrhosis. How we can develop model for their survival predictions. So one of the data is close to 8,000 patients. We have taken these parameters and we have developed, this is a XGBoost model, who is showing that close to 90% accuracy in training, and overall data set is 80%. And very simple parameters you can see here. The what you are using index as HE. Diagnosis is clarified into three things, either acute decompensation or ACLF or the cirrhosis decompensated, INR, creatinine, bilirubin, acute insult etiology, prior decompensation history, whether he is having hepatic, extrahepatic insult, leukocyte, and the duration of the current illness. If these parameters we are taking, then we are getting a model with 80% accuracy for the prediction of mortality in 3 months. But most interestingly, we are able to develop a decision tree because you cannot use all the parameters. The decision is very interesting that first you ask the history of hepatic encephalopathy. If he is having hepatic encephalopathy, if INR is more than 1.8, he ultimately becomes a high risk. So any patient cirrhosis coming to you having hepatic encephalopathy, INR more than 1.8, the 80% chance that he is a high risk group likely to have a mortality, and mortality is close to 81% in 3 months. If he is a high risk group, INR is less than 1.8, is the diagnosis acute or it is a hence liver disease. And you know, acute disease has a poor good survival, so that will be reflected as a low risk. Whereas if he is having onset liver disease, non-acute decompensation, then output is on the higher side. So it's very much compared to the clinical sense, the dysentery. If he is not having hepatic encephalopathy, INR is less than 1.34, he is a very good candidate to survive for more than 3 months. If it is more than 1.3, then he is coming as the intermediate group. So this is nearly completed our manuscript we are going to submit. And interestingly, we can see here the compare the convenience parameters, this is CTP and MELD. We can see here the CTP accuracy is 73, MELD is also equal 72, whereas our accuracy is coming as 88%. So this is one good to be replicated. The similar in the global data set from the CLEAR study, they have told that those patients admitted for the index time and how they are surviving for 30 days. You can see here the reason for admission, TLC, MELD score, income status. So these are the parameters that is better than the conventional parameters predicting outcome with accuracy close to 78%. So this is a model that for the prediction of the outcome at admission. If you think of SLF, which you most often have the ARC database, we thought of developing few models. So this is one product published, Nipun as the first author. What we have done here, if a person is coming with the SCLF, you have the 7 days parameter, and you are getting accuracy close to 99%, that if serum creatine at day 7 is high, that is more than 1.5, they have a circulatory failure, the mortality is close to 90%. So this is the AI model as able to accurately predict mortality at a day 7. So this is also one I think we can validate further. Then important one is the prediction of organ failure. So we have taken 16 patients data, organ failure is close to in 86%. So what we have done, taken 34 features, we have reduced to 24. Then analyze the top 20, 15, 14 features. The XG model has shown close to 90% having accuracy, and the top 3 parameters are presence of SARS, ascites, alcohol as the etiology, MAP is on the lower than 65, and serum albumin. So this is a very interesting parameter that if person having ascites, alcoholic, having a low BP and low albumin and SARS, they are likely to chance of getting an organ failure in next 7 days is close to 90%. So this is how you can see here this model is behaving like. And further, the most important always becomes the decision tree, because you want to know how to stratify the patients. You can see here the among the 16 patients, if MAP is low, that is below 79, they already at the high risk for developing organ failure. If BP is still on the higher side, if the albumin is less than 2.8, they are getting the high risk of organ failure also. So alcohol etiology, MAP is less than 79, and low albumin are likely to develop organ failure next 7 days. Those having not alcoholic also, if they have a low MAP, they are also, that means MAP is one of the important factor, and etiology is one of the common factors to predict who are the high risk or the low risk. Then if you think of this as a model, this is permitted, then prediction of the infections. So this is of same taken in 1600 patients, that if those patients coming with no infection, the developed infection is close to 25% in last 7 days, first week. The drivers for them to develop is R score, renal failure, circulatory, BP, heart rate, GGT, MAP, both BP especially diastolic are coming up, and then it's showing that the precision is close to 94% and accuracy is coming more than 92% for the random forest, and exhibits as highest 95. So this is also predicts that you can predict the development of infection in the next 7 days with accuracy with these parameters. Then this is what we submitted this year, that SLF who can develop AKI from the ARC dataset. You can see here the analysis taken for 3,300 patients and data is splitted here. So this is the models you can see here. The XGBoost is having highest than 95%, and these parameters are very simple and dual parameters, that is INR, WBC, platelet, urea, potassium, ascites grade, sodium, etiology, albumin, bilirubin. So among these, the top 5 parameters are showing a good accuracy for the parameters. And if you think of the parameters analysis, the decision tree, just to simplify the process of the flow, if bilirubin is more than 32, if INR is become more than 3.2, then they are likely to develop a AKI in 4 days. Sorry, this is taken as the day 4. Sorry, day 7. But data here, I will come to the limits of the study, that if bilirubin more than 32, INR is more than 3.2 at the baseline, they have a 80% chance that they are going to develop AKI at the day 7. If it is less than 32, if more than is 59, they are the moderate risk group. If bilirubin is less than 32, younger is the chances on the lower side. But problem here that we have the dynamic models where we want the parameters on the day 4. So I think most of the AKI will happen already by the day 4. So that's why this is a criticism, and we are getting the new data from the ARC to go for the better. But problem is that in ARC data is available day 0 and day 4. So that's why we are stuck up with this. And I will take MP from everyone and sir also how to make this paper one good one. Then comes the liver and brain axis. That is an emerging area, the liver brain axis. You can see here the brain and the liver is interlinked, and the most important area is the MHE, which needs to be diagnosed, prevented from the overt hypertension because having high mortality. And these are the parameters, the executive functions. You can see here the tests are the Hughes, and the gold standard is PHS, but the PHS is difficult to do because it takes 30 minutes to happening. So now this comes up the agentic AI. What Dr. House was there, the repeated stepwise questions to be asked to the system has now been bypassed. The agentic AI takes the data, takes the action planning, goal, and reasoning. They get reaction from the environments. do the actions, and they come as a recommendation. That means you have to put the data, your objectives, and then the internal flow because of repeated trainings and getting the feedback from the trainings, they provide actionable points. And that's why it is now coming everywhere. You can see here imaging to action to consultation to ISO monitoring to plan. It can give you a decision based upon the history how to manage, and is now bigly coming the healthcare for the practical use. So with this, we have taken a project and is got the grant. What we are doing now, the patient who comes with liver disease, the voice is no more a voice is also a data. His eye movements, his hand movements, and his memory from the PHE score can correlate to the functional MRI or the MRS and can predict the HE and hopefully can feature the gradient. The next important is coming up the functional MRI. The functional MRI is the way forward for the tracking behavioral response to therapy. And we are proposed this idea, got the grant, and luckily the new MRI who's coming next month, we will having the full functional MRI, and hopefully we can get the correlation of the brain activities through the functional MRI with clinical parameters to prove how to proceed further. Then the next important coming up is the ammonia. You can see here previously and now also people can see the breath can able to tell the diagnosis, but the disease lies in the breath. And you can see here the ammonia is the big challenge for everyone, and to do validate, and your breath can give a lot of information about the liver disease. So with this, we have developed a sensor with AI integration model. You can see here, he is able to tell that how much is there. This is a prototype which has now trial, and this is the device which are going to get it, and luckily got the grant for this to develop with breath ammonia to be detected for the correlation to the blood. And with this, I just want to close. But before this, I want few requests to the authority. We need more of translation focused research, product based and innovation should be content. The trick was there initially, which is needs to be reactivated. We need this medtech. We need a data center in a Ecoben model. Our IPR, I think Dr. Nupam is here. We need more clarity on this, and we'll move to the next. With this, I want to thanks all my collaborators, contributors, and from all parts, from the ILBS, all departments, as well as from the IIT Delhi, IIT Jodhpur, and IIT Rourkela, SOA from the Odisha, and this is from the Coimbatore. They all giving help on the background to make these papers and activities ready. Thank you.
Thank you, Ashok and Harsh. I was initially very reluctant to take this lecture. Then I sent this lecture to 3 people, and 2 of them said it's okay. One said it's not worth. It is too heavy duty stuff. So I'm going with it. And thank you, Dr. Isha, for taking Saturday classes. So my knowledge of AI is as old as her classes. So the topic is artificial intelligence, defining a basic artificial neural network. So artificial neural networks are the base of deep learning. And in this, the basic is multi-layer perceptron. This is the base of all the deep learning. So we'll see today this one. So what is AI? AI is an effort to automate intellectual tasks that are normally performed by humans. So there can be 2 approaches. Number 1, there is no learning by the machine. Number 2, there is learning by the machine. So when there is no learning, it is called symbolic AI. Initially in the 50s to 80s, it was done. And approaches involving learning are machine learning, deep learning, generative AI, agentic AI, and so on. So next question is, what is learning actually? So all learning is representational learning. What does this mean? So this is the input features. They may be 100, 200, 500, any number. And then these are converted or represented with, they are converted into different forms. This transformed version. So the input is transformed, and these are the representations. Subsequent transformation is again changed, another transformation, another representation, and then finally output is coming. So this is learning. So if you look at the classical programming, in classical programming, what was happening? We have the input data. The programmer crafts the rules. The program runs and we got the output or answers. But in machine learning, deep learning, and Gen AI, we have the input data. We know the answers. If it is a labeled data, we know whether patient survived or died or whatever. And then rules are learned. So here learning is happening. So these are the approaches that involve learning by the machine learning, deep learning, Gen AI. Now, there can be various types of input data. Input data can be structured. You are aware of the Excel sheets. In a spreadsheet, this is structured data, but there are unstructured data also. For example, text, images, sounds, videos. These are unstructured data. And machine learning not only takes structured, but also unstructured data. So this is machine learning. In statistics, you can only put structured data. Now, in the machine learning, there is deep learning. Why it is called deep? Because it takes both structured and unstructured data, and the output is only structured in deep learning. But in Gen AI, generative AI, it takes structured and unstructured data, and the output can be unstructured also. For example, you give a prompt, it generates an image, it generates a video. This is Gen AI, generative. Unimodal and multimodal, previous speakers have alluded upon. Unimodal means only one of these modes. Multimodal means a combination of these modes, text, images, sounds, videos, everything combined. So again, we look at this diagram. Artificial intelligence is all of these things. Machine learning can be supervised, unsupervised, semi-supervised, reinforcement, self-supervised, or transfer learning. And regression, classification, these are the realms of statistics also. These methods are used in statistics also, and I will show in the next class. And actual machine learning is, or AI is deep learning, where it can be supervised or unsupervised. It is called deep because it has hidden layers. We will see what are hidden layers, and then can extract features from the data without the need for manual feature selection. There is no need to select what features you want to put. It will select on its own. This is deep learning. And artificial neural networks are the basic type of networks. We will see generative AI, agentic AI, we already know. Now, supervised learning means there is a labeled data to train algorithm. That is, there is human input, whether the patient survived, what was the HVPG actually measured. This is supervised learning. And basically two groups, regression and classification. Regression means to predict continuous variables, height, weight, BMI, HVPG, etc. And these are the commonly used methods we use in statistics also, linear regression, Cox regression, decision tree. These are part of the classical statistical methods also. Again, classification type means they are predicting categories, alive, dead. Logistic regression, XGBoost we have heard, support vector machines we have heard. So these are part of classical statistical methods also. Then unsupervised learning, there is no human input. We don't know what is the output. And then clustering can occur. Similar data points are clustered together. We know of hierarchical clustering. Dimensionality reduction, we know of principal component analysis. Then there is anomaly detection to detect the outliers. And there is associated learning. But our focus is artificial neural networks. And in that also, only this part, multi-layer perceptron. So these are the common types. Convolutional neural networks, we have heard Harsh talking about it. These neural networks can be 1D, 2D, 3D, 2D processes images, 3D processes videos. Similarly, recurrent neural networks, we have heard LTSMs, we have heard transformers, we have heard in the previous lecture. There can be text transformer, vision transformer, time space transformer, various types. So we need to have some basic knowledge about linear and logistic regression because this is the base on which we will build. So we know in linear regression, these are the input features. It goes into the linear regression and the output is a single number like height, weight, actual PG. And this Y is the output. Beta 0 is the intercept. Then this is the coefficient. This is the input, coefficient, input, coefficient, input. Coefficient and inputs are multiplied and added with the intercept. So in statistics, it is known as beta 0 is known as intercept, and these are known as coefficients. But in machine learning or AI, the same thing is known as bias, and this is known as weight. So intercept is known as bias, coefficients are known as weights, and these are parameters. Then there are hyperparameters also that I will tell you. And if we look at the logistic regression, these are again the input features. And what logistic regression gives out is a probability. The first step is same as the upper one, where it is called Z. Z is the logit. You must have heard the word logit. Logit is same as the previous equation. It is the same beta 0, intercept or bias, then coefficient or weights for each input. And then after this, Z is fed into this formula. Don't bother with this formula, where it gives the probability. So in linear regression, directly we get a single number. In logistic regression, we get a single number that is again converted into probability. And finally, we get a sigmoid curve where probability varies from 0 to 1. So this is sigmoid function. We'll come back again regarding this. So what is a basic artificial neural network? We have the input data. The computer will not understand your input data. It has to be converted into tensors. I don't have time for discussion on this, but you just remember that it is a bunch of numbers that can be understood by the program, by the neural network. And neural network input layer is there, data goes here. Then there are hidden layers. These layers are learning the patterns in the data that can be many, 1, 2, 3, 4, whatever you like. And this is the output layer. Output layer again is in the form of tensors, which needs to be converted into output. So what is a perceptron? I told you multi-layer perceptron. So what is perceptron? Perceptron is a neuron. And this is one neuron. This one is one neuron. This one is one neuron. And we have to understand what are the various types of outputs because we have to make selection of many of the hyperparameters based on this. So outputs, sorry. So output can be single number like height, weight, etc. It can be a vector of n numbers, multiple outputs. It can be a single probability, alive or dead. It can be multi-probability, like in pathology, malignant, non-malignant, indeterminate. There are 3 classes. So this is multi-class classification. So first let us understand why it is called a neuron, a perceptron. This is a diagram of a neuron. It has dendrites. This is the body and this is the axon. The signal comes from here, goes here and output is there. So similarly, this perceptron, we have inputs and weight we have seen. Input second in its weight, input third, input fourth, and this is the bias. So these represent the dendrites taking inside the body. And this is the neuronal body. And this is the output value. We'll see what is happening inside, what is sum and activation, we'll see next. So what is inside the single neuronal body? So we have seen this, x1 into weight 1, x2 weight 2 plus bias. This is the linear function. This is called linear function. Remember, this neuron has 2 parts. One is the linear function and one is the activation function. So these all inputs are going inside and it is sum of input into weight plus bias. We have seen, we add all of these And this function is fed into another activation function, which usually is non-linear. So there is a linear part inside this, then there is a non-linear part, and then output value occurs. So this is the dendrite, body, and the axon. So once again, this is the linear, non-linear, and this is the neuron. This is the neuron, this is the neuron. So one neuron is linear plus non-linear. And we stack these neurons, put them one above the other, and this is called a layer. So this is one layer, another layer. Each layer has a stack of neurons. Each neuron has linear, non-linear, or activation function. And then when we have selected the number of layers, then feed into the logistic part. Layer of neurons, the stack of neurons is called layer. So this green part is one layer, second layer, third layer. So once again, naming of the layer, input layer, this is the hidden layer, this is hidden layer 2, and this is the output layer. Now, when every neuron is connected to each other, then it is called the dense or fully connected layer. So dense means everything is connected to each other, it is dense. So if we look, what is regression? It is actually a neural network where there are no hidden layers. This is the regression, and these are the neural networks. If you remove this part, hidden layers, then this is equivalent to the regression. And we have heard about the activation function. This is the activation function. This is the linear part. Linear part goes into the activation function. Now, what is activation function? This is a function. We know about the linear function. So A goes inside the function, and what comes out? This is A, and this is the output, and both are in a straight line. This is the sigmoid function we have already seen. Probability varies from the 0 to 1. This is the formula, don't bother with it. Then the ReLU function. This is the most common activation function used in AI. Everywhere you will heard ReLU. And what this means that if the input is negative, it is converted to 0. If it is positive, it is taken as. So these are the three activation functions that are used. Now, what are the steps in AI model development? First, data collection, then pre-processing, splitting data into three sets: training, validation, and test. And our focus is defining a model today. So building a model has three steps. First, you have to define what model you want. Then you compile the model. Compiling has three functions: loss function, optimizer, and matrix. You just remember these words, LOM, and then fit the model, then evaluate, then improve through hyperparameter tuning. Continue this process, evaluate, tweak, tweak, evaluate, tweak, and then reload and use the model. So basically every data is split into training, validation, and test. So training set is on which the model is learning, which is 70 to 80%. Validation, tuning occurs on this validation data, and test is the model gets evaluated. So there is a term generalization. That means how the model will perform on data which it has not seen. That is, it has not been trained on. That is generalizability. So let's see how do these are the steps for building a model. These are the inputs. This is the network. Now, how does the model select weights and biases? So initially it is random. It will collect random weights and biases and start working on those. It will give some prediction. We know what are the true targets. Then this is the loss function. That means how far is prediction from the true target. So there are various loss functions. I don't have time to go into all those, but remember that there is a loss function, and the purpose is to reduce the loss so that the predictions are as close to the targets. And how this is done? This is done by an optimizer. So to minimize the loss, model will hire an optimizer. So what the optimizer will do, it will update the weights and biases. Then this model will work with the updated weights and biases. Then again will give a prediction. Then again see how far it is from the true target. Then again the optimizer will optimize the weights and biases, and this cycle will continue till loss function is minimized. Now, metrics are the functions used to evaluate the performance of the model, like AU, ROC, sensitivity, specificity, accuracy. These are the metrics. So there are various kind of matrices. Now, what is underfitting, overfitting of the data? So this is the error. Our purpose is to minimize the error. And this is the number of epochs. Epochs mean how many times the model is going through the data. So if we train, just forget this line, you focus on this line and the training set. If the model is trained for sufficient amount of time or sufficient number of epochs, then ultimately we'll see that error is approaching to almost zero, because it is learning all the features, it is remembering everything fed in the trained data. But in the validation set, initially the error will decrease, but after some point of time, the error will continue increasing. So here, underfitting is occurring. At this time, overfitting is occurring. And this is the point where our model has to stop. We have to say that stop, and we will use this cutoff point as the finality of the model. Sorry. Here. This is the number of epochs. I mean, how many times you can define number of epochs. You want 10 epochs, 100 epochs, 200 epochs. So when you get this graph, if you feel that this is 10, then you define the model and number of epochs you put as 10. So output layers and loss function in different scenarios. We have seen the outputs. These outputs are very important because for a single number, the output layer activation will be a linear and loss function will be mean squared error. If there is a regression with multiple outputs, there will be a stack of linear functions. The straight line is a symbol for linear. Then again, loss function will be mean squared error. If there is a binary classification, live, dead, then we have seen sigmoid function will be there, and loss function will be used as binary cross entropy. This is another class in its own. When multi-class classification is there, for example, malignant, non-malignant, or indeterminate, then softmax is to be used and categorical cross entropy is to be used. Now, what is softmax? If we have one probability, then there are two outputs and the probability varies between 0 and 1. Suppose there are 10 outputs, then each output will have some probability and the sum of these probabilities will be equal to 1. So if we have 3 outputs, then sum of all these 3 outputs should be 1. So this is called softmax. So I don't have much time. So my purpose was to see how to define this. Then there is a compile. Compile has, we have to give 3 functions: loss, optimizer, and matrix. Optimizer reduces loss function by gradient descent. Just familiarize yourself with these words, gradient descent. And gradient descent is calculated by back propagation by epochs. And this is the model fit. So this is the last few slides. This is the basic architecture of convolutional neural network. I don't want you to bother with all these layers. I just want to focus on this. This fully collected network, or what I have discussed, is only a part of this network. And this basic network is a part of many of the network like RNN, transformers. All these will have somewhere this network. Thank you for your attention. Don't bother with all these codes. It only indicates that with these 6 lines we can code whatever I told you. This is the input layer we have to define. These are the hidden layers you have to define. 64 is the number of neurons. activation is the activation function you want to use. This is the hidden layer 1, this is the hidden layer 2. Output, again, this is the number of neurons, what kind of activation you need. And these are the compilation steps. We need to give what is the optimizer, define it, what is the loss class, define it, put it into the model, optimizer, loss, and matrix. And thank you very much.
Thank you, Manoj. It was very heavy duty.
Yeah, that's why I was very reluctant to present this.
One thing is clear, we all have.
But these are the
that
words that you must be familiar to read any paper
Yes.
or you want to develop
There is,
any model. You want to collaborate with our engineering colleagues. So you should have
there is
basic
no
idea.
escape. We have to learn, and you have shown how leaders start themselves to lead by example. All of us will be doing this. I'll request Isha to maybe take more classes for us, and maybe now we don't have, but classes are here now, and all of us, every DM, MCH, PDCC should now be having one part of the thesis as AI generated or AI related things. So thank you. Much more to be done. And with it also be ready for, where is Dr. Daga? Daga sir, what is to please announce programs?
So we have a convocation ceremony tomorrow. You all be here by 11 sharp. And prior to that, I think today evening we have at 4 o'clock the, all faculty is supposed to come here for a rehearsal. So I request all faculty. And tomorrow again at 11, we should be all here occupying our seats. Yeah, I'll let the alumni lead that. So that that's for,